Welcome to Duke Spine Institute. This is a live stream. Our patient has degenerative disc disease of 5 discs, L1-2, L2-3, L3-4, L4-5, L5-S1. We're going to attempt to repair all 5. We start with placement of the needle, and that way we gain access to the disc. He has pretty bad arthritis and curvature of the spine. I actually started a little bit higher, and I think I had better entry point. So this surgery is designed to repair degenerated discs that are causing symptoms like back pain or leg pain. And the first thing I have to do is get into the disc. Shot? All right, let's figure out why maybe we're just too, I think we're just too lateral. Shot? So the first thing I have to do, folks, is get into the disc that I want to repair. That would be the L5-S1 disc. And shot, I'm encountering a lot of challenge because of his anatomy. He has really bad arthritis, but also he has a iliac crest that's blocking me, and he's got facet arthritis. You can see the facet arthritis. Jordan, show them. Shot. Yep, it's all that big, gigantic facet. Shot. So I'm going for L5-S1 first. It's always the hardest to get to. That's why I like to do it first. AP, you can see the needle is at L5-S1. We're heading towards that disc. Now we're going to do on the left side 5-1 and 1-2. We're going to do on the right side L2-3, L3-4, L4-5. Yeah. Perfect. Lateral. So you can see, look at that picture, Henry, how curved his spine is. That's scoliosis. It's twisted. You can see the spinous process is rotated. The whole spine is twisted. But for many years, I used to tell patients, we have to fix your scoliosis to get rid of your pain, because that's what I believed. And unfortunately, that's what a lot of doctors still tell patients, but it's not true. The truth is, all you got to do is fix the tear that's in the back of the disc, and then you fix the back pain. We're in. It's a miracle. I'm surprised I was able to get in there. That was hard. Okay, so on the left side, I'm doing 5-1 and 1-2, right? Everybody agree? No, I'm not making an incision yet. I cannot get to 1-2 with the same incision. I'm going to have to go up. All right, so there's 5, 4, 3, 2, 1. If you have questions, feel free to ask me. I'll do my best to answer them for you. Let's go to 1-2 and see where shot. Close. 5, 4, 3, 2, 1. A little bit higher than I want to be. And shot. All right, that's looking better. AP. So I'm going to be moving quickly because our patient is asleep and he's on propofol sedation. And we want to keep the surgery moving, so I have to move quickly, but I'll try to answer questions in between. In the meantime, Henry, let's show the audience the 30 different causes of back pain that we commonly see.
Of course.
I'm Dr. R. Duke-Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. Okay, welcome back. You can see from our video there are 30 different things that cause chronic back pain. This patient has a lot. He has 5 and then basically 14. So he has about 20 causes. He has the SI joints, the facets, the discs, and he wants them all fixed today. If we can, we're going to do our best. It just depends on how he does with the anesthesia and whether he tolerates it well. Shot. And we'll just have to wait and see. AP. So far I've got 3 needles in position. I need 2 more to get all 5 discs fixed. Things are going pretty well. Of course, so I'm hitting the transverse process. That's the problem. Things are going pretty well, but I'll be honest, this is a very, very difficult case. This is as hard as they come. All right, so I'm hitting the TP because of the scoliosis, so I need to be higher up. And I may have to make a separate incision for that because I don't know if I can get this. Shot. Let's see, shot. All right, I think I'm just at the top of the TP there. You see that? Shot?
Yes, we do.
The TP, show them the TP in that picture. Shot? Yeah, I'm just above the TP. Can you see the TP? Nope. To the right. See that circle? Yes. To the right there. Yes, that circle there. That is the transverse process. So I'm slipping right above it. So let's go for an AP view. This is on a level of 1 to 10 difficulty. This is a 15. This is off the chart because of the scoliosis, the collapse of the disc, the degeneration, the facet arthropathy, hypertrophy of the facet joints, just the curvature, and he's a big guy, so it's just not easy. But I want to fix this man and get rid of his pain. He's a good man. All right, we have any questions?
At this moment, no current questions.
All right, so, shot. I'm going to do my best for him as I do for all my patients. Shot. I think we're in. AP, verify. Got one more needle to place. Go ahead. Shot. Lateral. Yep, lateral. We're in. Last one to do on his right. Everybody agree right is 2, 3, 3, 4, 4, 5? Shot. All right. Getting close. How's he doing, doctor? Shot. Shot. Remember, the spine is curving away. Shot and then AP. I think that's too lateral. Give me an AP. All right, let's show people why we do this surgery. Yep, too lateral. Henry, let's show people why we do this surgery. Why do we do the Duke laser disc repair?
Of course.
How does this surgery work?
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. So we just showed you how the disc causes pain, and have we shown them how we fix this pain, Henry?
Not yet.
Let's do that. All right, we're going to show you not just the cause of discogenic pain, but also the way we fix it. Can you get me a better AP at 2-3?
Disc injuries start with an annular tear. Damaged nucleus, pulposus, herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. Damage to the bones or soft tissue debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see from the video that we use a laser to debride the tear in the back of the disc. That tear is the source of inflammation and pain. All right, I have one more disc to access. That's the L1-S1 on the right, Sean. And it is very challenging because of the curvature. AP. AP stands for anterior posterior. It's a front to back shot. We're doing lateral views mostly. And let's take some questions.
First question coming from Alan on Facebook,
Yes, of course, Alan on Facebook.
asking how common is bilateral cervical pain? I have issues with both thumbs coming from C6, I've been told. Thanks. Love watching
Shot.
these videos.
It is possible you have it, but Alan, the best thing to do is to do a free MRI review with us, Sean. I actually do it with you myself. I will look at your MRI and I will tell you what's wrong and how to fix it. You may need a nerve test to see if you have a pinched nerve in your elbow or wrist or your neck. But generally speaking, if you have neck pain and it shoots down into your thumb area, then you probably have a herniated disc that needs to be fixed. All right, we're going to get started in just a moment with the laser surgery. I've just got to see if I can get this last needle in place. Shot. This is probably the most collapsed disc of all. Shot. And you can see I'm at the back and I'm really struggling to get in. I guess I could try shot with him being asleep and see if I'm able to. But I'm hitting bone right here. Shot. I did feel it move a little bit. Oh, maybe we're there. Again, this is truly the hardest to do because of his curvature, his collapse of the disc, the amount of arthritis. Shot. But I think we could probably get that one. We're going to not start with it. Okay. We're going to just do a chromodiscogram. Shot. 5-1. Perfect. We're in the disc. And then the next is going to be 3-4. Yep. Perfect. And then 4-5. Shot. Perfect. Perfect. So the other two needles at the top, because of the curvature and the collapse, I have them at the back of the disc. I'm going to have to wait and do those later. I'm going to start with the ones that I'm for sure in. That's going to be the 5-1. Will be our first one. Any questions? Type them up. I'll do my best to answer. I know you have some more questions.
Yes. This next question is coming from Pawn Lust on YouTube.
Han?
Pawn, P-A-W-N.
All
Lust.
right.
Yes.
Nice to meet you, Pawn. Thanks for joining us.
Asking, is there a safe and minimally invasive way of helping arthropathic unconvertebral joint augment issues? The neck started to crack, pop, and grind a few months after a neck injury, protrusions and bulges.
Yes. So there is. We just did it. So if you go back to YouTube and look at the surgery we just did, it was for facet pain, which was what it sounds like you may have. You may require not just facet treatment, but also disc treatment. And we can do both here at Duke Spine in the same surgery. So it'll take me about an hour and a half to do both. Shot? All right. But yes, it's the Duke laser disc repair for disc problems and the Duke plasma rhizotomy for facet. We need a little bit more sedation. Shot? Okay, so we're right near his painful facet, and that's probably why he's uncomfortable. He's a little light. Let me give some more numbing medicine. But look up Duke laser disc repair cervical, and then also the Duke plasma rhizotomy cervical. Those are the two procedures you probably need. But the truth is, you should just get a free MRI review. We don't charge for it, and get a real diagnosis. What's causing your symptoms? Otherwise, you could end up getting surgery you don't need and don't want. You want least invasive, most effective, most durable, safest. Shot? All right. Are we okay, doctor? Yep. I would give him a little bit more. We're right at that painful disc. Let's get an AP to verify position. So our patient is not intubated. He's not under general anesthesia. He's under sedation, which is propofol sedation. It's the best way to do the procedure. And that said, he is going to be breathing on his own, and that's what we want. All right. But because this is such a painful area, he's feeling that pain as we get closer. Shot? All right.
We have
Sean?
another question.
Let me just see. AP? Yeah, we'll take the question.
Coming from Lanu on YouTube.
Sure, Lanu.
Asking, I have a stupid question. I saw some difficult surgeries that lasted over 10 hours in a major hospital. Do any surgeons ever wanted to go to the bathroom?
Yeah, we do. Absolutely. 10-hour surgery is very difficult, and for the surgeon as well as the patient. I don't do 10-hour surgeries anymore. I think, I'm not sure what 10-hour surgery you watched, but maybe it was neurosurgery, maybe it wasn't. But yes, we do have to go to the bathroom, and what happens is you get somebody to come in and relieve you, and I don't mean relieve you like to the bathroom relieve you. I mean they come in and operate for you or monitor the patient while you run off to the bathroom. I've had to do that in residency before. Let's pull back a little bit, see where it is. And you just run off to the bathroom, shot, you get some water, pull it back more. You get something to eat, usually, and then you come back. A little more. All right, it's good. So we're all human. We do have to go to the bathroom. We do have to eat something, or our sugar goes too low. And so, yes, we do take breaks. The longest surgery I've done is 17 hours with my attending at the VA hospital in Gainesville when I was working at the VA as a neurosurgeon. And both of us had to relieve each other. He would take off and go have a bathroom break and something to eat and drink, and I would go and take off. So you work as a team. All right, we are inside the disc. You can see the blue dye. That means we're in the disc at 5-1. This was one of the harder ones to get into. And we're going to be taking out pieces of herniation. This is where his pain is coming from, L1-S1. I'm going to bring the laser in, and we're going to start using the laser. Any questions?
Yes, we have a question coming from AAKK on YouTube.
Hello, AAKK, welcome.
Asking, with the addition of DLDR and facet treatment, are there any other pain generators in the spine with a patient's level of scoliosis as in this case?
Hey, great question. So, AAKK, very smart. You are correct. We are treating the two most common causes of pain, the disc and the facets. Are there any other causes? Yes, there are fractures, but he doesn't have fractures. There's also sacroiliac joint, and he does have SI joint pain. We're going to be treating that as well. And then there's piriformis, which he does not have. So of all the causes of back pain for the lower back, he has every single cause except for piriformis and fractures of the vertebral bodies. And the scoliosis never causes pain, ever, in the spine. Now, if you have really bad scoliosis, really bad, you can get rib pain when your 12th rib hits your iliac crest, which he does not have. And you can also get eventually muscular pain because your spine is so twisted, but he does not have that either. Grabber? So all of his pain sources, I believe, are coming from disc and facet, and I think he's going to have pretty close to 100% pain relief with this surgery, as long as I'm able to get everything done. So far it's looking like I can, but it is not an easy surgery. It is not an easy surgery. And I may have to bring him back and do his SI joints at another day. It just depends on my anesthesiologist. because we're honestly treating a lot, and a lot more than we normally do. But I'm trying to help this man by doing all of his surgery at one time. Okay. So anyway, you can see herniation. And I think we're out of the disc at this point. We've done everything we can do. He has pretty severe nerve pinching and radiculopathy. But I really think this surgery is gonna give him his best chance of getting rid of his symptoms. Huh? Yeah. Let me just staple this. So we've done one, and now we're gonna let me try to get 1, 2. I'm gonna try to do the 1, 2 now. See if I can get into the disc. You can see on the x-ray the dye leaking out the back of the disc at number 4-5. Pretty bad. That's a giant herniation pinching the nerve right there.
We have a couple more questions.
Sure.
Next one coming from Pawn Lust once more on YouTube,
Hello, Hanlust.
asking if the laser zaps a bulge and protrusion, would this increase the chances of future disc degeneration? I ask because the annulus isn't yet torn in a bulge. Thank you.
Yeah, so a bulge is an annular tear. It's the same thing. Shot. A bulge and an annular tear are the same thing. And a annular tear is torn in a bulge. A bulge is just a small herniation. It's still a herniation. You cannot have a bulge without a herniation. The nuclear material must push through the annulus and bulge out to have a bulge. There is no such thing as a bulge without a herniation. That's a lot of people don't understand that. But that's a fact. It's just a small herniation. Let's have some numbing medicine. So all disc bulges are disc herniations. They're just not big ones.
This next question is coming from...
Hold the guide wire down. All right, let's see. Go ahead.
Going
Shot.
from Lanu once more on YouTube,
Hi, Lanu. Thank you.
asking, can facet joints and disc repair be done on the same day?
We're doing it right now. Let go. All right, let's get an AP. We're doing it right now, Lanu. We just did his cervical facet. We're doing his discs, 5 of them, and then we're going to do his facets, and then we're going to do his SI, as long as we can. We don't know if we're going to be able to get it all done, but we're going to do our damn best trying. Shot? All right. So we are... I'm not happy with that. Can you get a better AP? Get that spine. Nope, other way, Jordan. Shot. Yeah, there's too much lateral aesthesis there. I don't like that. I'm not sure I can get in there. Shot. All right, lateral. Shot. I'm going to try. I feel like we're not getting a true lateral. Can we get a better lateral? Maybe change the orbit a little bit. Maybe we are. Shot. All right, go back just a little bit. Shot. Isn't it weird how the dilator lines up with the disc on the lateral, but on the AP it seems like it doesn't? I'm going to try a little bit here, and if I can't get it, if I'm not happy with it, I'm just going to stop, because I don't want to cause any problems for him. That these surgeries always have a risk of complications, but they're very safe. We haven't had complications, and I don't want a complication, but this kind of a curvature of the spine, go ahead and take the guide wire out, is very difficult. Yeah, shot, that doesn't feel right. Nope, we're sliding. We're sliding, so that's not going to work. Shot? Yeah, there's just no way to get into that disc. All right, we tried, but we couldn't get in to 1-2. All right, I'm going to come over to the other side. Any other questions?
No current questions, so we do have a comment from Lanu once more on YouTube saying the spine looks very curvy.
It is. Yeah, the spine is extremely curved. It's called scoliosis, and it's due to the degenerative disc disease that he has. Shot. So it is actually his degenerated disc that's causing it. The discs are collapsing. The facets are also collapsing from arthritis over the years, the weight of his body. And the spine never collapses symmetrically. It always collapses asymmetrically. So one side collapses more than the other, and that creates a curve. Shot? He definitely has a curve, and it's a big one. That said, he doesn't want fusion, and I don't blame him. Fusion would be the alternative treatment. If I did a fusion on this patient, I would take his facets out because the nerves are being pinched severely in the lateral recess and foramen, and I would take his facets out, and I would do interbody cages and try to correct some of that curvature if I did a fusion, but I'm not doing a fusion, obviously. Shot. All right, so the 4-5 disc is probably the biggest disc he has. You could see all the dye in there. 3-4 is the next biggest. 5-1 was severely collapsed and bad stenosis. 1-2, 2-3 are severely collapsed as well. So just giving you a rundown on the structure of these discs, what I'm seeing here in the operating room. I could not get to 1-2. We're supposed to do it on the left side. I could not do it. It is too collapsed and too curved. It's not safe to proceed. So I had to abort 1-2 on the left. We have all these Ratex here. Any other questions?
At this moment, no current questions.
All right. Well, let's show our audience how facet joints, the second most common cause of chronic back pain, how they cause pain.
Of course.
Okay, welcome back. Unlike the last disc, 5-1, this disc is pretty full of disc material called nucleus pulposus, and you can see it here. I've already grabbed out a few pieces of herniation. There's another piece right there floating out.
We can see it, yes. And we have another question.
I'll take your question.
And another one coming. First one coming from Lanu once more on YouTube, asking, "Is there such thing as spinal transplant?"
There is spinal transplant. Not in America. In China, yes, but not in the United States. And I don't think there ever will be. I don't see a reason why to do it. Not for back pain. Maybe if you have tuberculosis of the spine and it's destroyed your spine, that might be an indication, but I just don't see it ever happening. I don't see an indication for it. Now the Chinese are doing it because they think they can solve back pain by taking the spine out and replacing it with a young person's spine. But that's extremely dangerous, unnecessary, completely unnecessary, and you're going to have to be on immunosuppressive drugs the rest of your life. It's a horrible, horrible idea. I would never do it, and I would never recommend it to anybody. Great question.
Next question coming from Joseph on YouTube, asking, is it common to insert a cage from a posterior approach?
Yeah, Joseph. So cages in the lumbar spine, that's the lower back, can be inserted front, side, or back. There's 3 different ways. The original way they were inserted was through the back. That was the first, through the front. I apologize. That was called the BAK cage. It was back in the 90s, through the front. Then somebody developed an approach going through the back called a PLIF, PLIF. And then the TLIF was the next evolution, TLIF. And then there was the XLIF, which is from the side, and then there was the OLIF. So there's really all the evolution of placement of cages in the lumbar spine has gone from front to back to side, and now, just depends on what surgeon you go to. They choose where they want to enter and put the cage in. Also depends on their training. But the complication levels are very high for a posterior cage, for an anterior cage, and they're lower for a posterior cage. They're the lowest for posterior cages, but again, it depends on your surgeon's training. If your surgeon is trained to do anterior only, and you ask them to go posterior, they're going to have a higher complication rate. So really, the best surgery if you're going to put a cage is through the back. It's a posterior. But you need a surgeon who is good at it to do it for you. Otherwise, your complication rate is very high. You don't want a complication if you can avoid it. Complications do happen in spine surgery. They're quite common, as a matter of fact. And you're dealing with the spine, which is obviously an important structure. So infections, spinal fluid leaks, instability, hardware failure, failed fusions, nerve damage, CSF leak, all these things happen as part of spine surgery. But as a patient, you want to try to find the surgeon with the procedure that has the lowest chance of a complication for you, so you don't have to deal with that kind of a complication, okay? But ultimately, complications do happen. They're part of spine surgery. That's why we do what's called informed consent. The fact is that certain procedures have a lower complication rate than others. Certain surgeons have a lower complication rate than others. So ultimately, you want to find a procedure and a surgeon that gives you a safe procedure that you hopefully don't have any problems from that surgery. Okay? I've had complications in my surgeries. Not the Duke laser disc repair, but we've had complications in other surgeries, like my fusion. I've had infections in the way past, many years ago when I did them, not anymore. We do things now that are different with those fusions. I use antibiotics inside the wound at the end of the surgery. We use drains that we did use before as well, but we also operate pretty quickly to reduce the chance of complications. 10-hour surgery fusions have a higher chance of complications. They could be surgical complications, they could be anesthesia complications. So in the end, you really want a procedure done that's the safest by the safest surgeon that does that procedure. That's the goal for everybody. For example, I would not do an ALIF on my patients. That's an anterior lumbar interbody fusion, because I don't have the right support staff to do that. And that surgery has a higher complication rate than a TLIF, much higher. and everybody knows that, but still doctors do it because that's all they know how to do. A T-lift, you're dealing with the nerves in the back of the spine, and the chance of neural complications is higher from placing a cage past the nerves. But if you have a surgeon who's done a lot and they know what they're doing and they do a good technique, then the chance of complications is very low. All right, we're almost done with this disc. We're near the end of the disc. You can see the white fluffy stuff is herniation and ligament called foraminal ligament. And then there's some fat at 12 o'clock, but we're almost done here. One other thing I worry about with the patient laying on their belly is, I've had this happen before, where the patient lays on the belly for hours and then they wake up with what's called a neuropraxia, where their nerves aren't working properly. And that typically happens in people with spinal stenosis, not just back pain. This patient has spinal stenosis, so the longer he's laying on his belly, the higher the chance of getting a neuropraxia from pinching of the nerves in the foramen, which I'm worried about. So the longer the surgery takes, the higher the chance of complications. Okay, you see that? There's a relationship between the time that surgery takes, the type of surgery, and the risk of complication. We don't do very many surgeries that are this long, so I have to hope that our patient does good, but there's always a chance that his nerves will get pinched while he's laying here. Because when you're laying in this position, you're in extension. Your lumbar spine is extended. And an extended lumbar spine is causes narrowing of the foramen. So, but neuropraxic injuries always get better in time. The patient may have some numbness, weakness, but that usually goes away over time. Usually several months, unfortunately, but that is one of the risks of doing these surgeries, any kind of back surgery, when the patient is laying on their belly. You don't have the same risk when they're laying on their back for an A-lift. But, like we talked about, A-lifts have other complications and a much higher rate of those other complications. Okay, grabber, just about done with this disc. We're going to move on to the next one.
At this moment, no current questions. So in the meantime, why don't we show the audience how it is facets cause back pain. Why don't we show them how it is that we cure facet pain?
I love it. Let's do it.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see that facet joints cause back pain and that we fix it with a procedure called the Duke plasma rhizotomy. It's only available here at Duke Spine. Bring in the fluoro. It's actually a patented procedure. And we are destroying pain nerves when we do that procedure, but just pain nerves, not important nerves, just pain nerves. Lateral. Any questions?
Yes, we have a
Let's go, Jordan.
question coming from AAKK
Shot.
on YouTube. once more, asking, with your description of neuropraxia during surgery, have you ever seen neuropraxia from central canal stenosis in the cervical spine while operating on the lumbar from prolonged positioning?
Yeah, it's a great question. I have not in my patients, but yes, in other patients. I've seen people with spinal cord injuries having surgery, other types of surgery, whether it's their teeth or orthopedic, whatever it is they're doing, they have some other kind of surgery. The anesthesiologist and surgeon did not know they had stenosis in their neck, and they end up with a myelopathic or neuropraxic type injury. So it does happen. It does happen. Shot? All right, let me get an AP real quick. AP. So we're going into 3-4. The good news is neuropraxic injuries do recover, but it just takes time. All right. Let's go back to a lateral. That looks pretty good. You can see how twisted that spine is. He actually has a graft there. You guys see the vascular graft at the bottom there? Bottom right? That's a graft for a blood vessel. Hold on. Shot? Yeah. We are in, and we're going to bring our tube in, and we're going to do the surgery.
We have another question
Yep.
coming from Faisal on Facebook,
Yes, Faisal.
asking, what's the worst spine injury
Bring it back.
you have ever seen and
Let's
had
see.
to operate on?
Oh, well, the worst spine injuries are paralysis. And I did a lot of that operations when I was in my training at the University of Florida, because we were a trauma center. So we took care of people who were paralyzed from car accidents or falls, and those are always the worst. Fracture, dislocation, traumatic, with spinal cord injury, complete. That's the worst spine injury I've seen. Unfortunately, it happens a lot in America, developed countries, because of high-speed motor vehicle accidents that happen. There are surgeons whose whole careers are spent treating those kind of patients. And for me, I enjoy this type of surgery more, where I can go in and cure back pain, chronic back pain, rather than dealing with fracture dislocations. I don't want to be in an academic center. I don't want to be in a large city. I like quiet, rural areas. And if you live in a city and you take care of those kind of patients, it's a completely different type of practice that you have as a neurosurgeon. And you have to work with a team of providers in the hospital usually. I really like having my own center, because I can control who I hire, what treatments we offer, how we do surgery, how we care for our patients. Watch the tube, please. Yep, grab the tube and watch it. A little bit of fat right there, you can see. But we're at the back of this disc right here. Lots of calcium, a lot of gold, and hard bone spurs. I'm using the laser to remove. I'm almost done with this disc. The good thing about having a disc that's degenerated that you're fixing is that there's not a lot of herniation material. There's very little. It's called disc osteophyte, and you don't have to work at it as much typically. It's quicker to get rid of. So that is the one advantage of this kind of surgery. You can see the inflammatory tissue right there. You guys see that, the pink stuff?
Yes, we do.
Any other questions?
Yes, we have a couple more questions. Next one coming from Laney on YouTube.
Before I take that, I just want to show you guys. See that crack down there, that gap, that canyon? That is the disc. We are inside the disc. Okay, and we're actually inside the tear of the disc, not the disc itself, but the tear, the annular tear, which is the back 2 centimeters of the disc. And anyway, you can see the big canyon is missing disc material. That's what a degenerated disc looks like on the inside when you put a tube in it and spread it open. All right? I'm still getting the herniation out in the back of the disc. That's what I'm doing right now with the blue stuff. But that's a disc, a degenerated disc down there. Right here. Hold it. Hold it. All right, we'll take the question.
Laney on YouTube asking, when you destroy the nerves that cause facet pain, is that similar to an ablation of a nerve?
Hold it. Yeah, so if you've heard of a procedure called radiofrequency ablation, it is a procedure that's been around for years. The goal of that procedure is to destroy pain nerves, the same pain nerves I'm destroying. The problem is it does not destroy pain nerves, okay? It doesn't work, and everybody knows that, and that's always been the best treatment for facet pain, but nobody ever figured out a real way to destroy those pain nerves. I did. And I use my technique. It's called the Duke plasma rhizotomy, and in America it's patented by me, and it is the best treatment in the world to get rid of pain nerves that are causing pain from the facet joint, the SI joint, any joint. The destruction of a pain nerve or any nerve is called a rhizotomy, where you cut the nerve. And radiofrequency ablation attempts to do a rhizotomy, but it doesn't work. Okay? So it fails. It's a failed procedure. It's always going to fail. Everybody knows it fails. That's why the doctor tells you the nerves grow back. They don't really grow back. What they do is they just didn't cut it in the first place. All right, but they tell the patient it's going to grow back. It doesn't grow back. It just never worked. The nerves get stunned. We call it neuropraxia. And that's all that happens, neuropraxia. But the technique, if you look at it, it's impossible to destroy the nerve unless you happen to hit the nerve head on, a bullseye, which is almost impossible to do. Okay? That's why the procedure doesn't work. It's not cutting the pain nerve, it's just burning near it. Come on in, Jordan. One more disc to do. So the only procedure that destroys pain nerves is a neurotomy. It's called a neurotomy, and that's what I do, a neurotomy. Nobody else does it. For some reason, I had to figure out how to do it, and now that I figured out how to do it, we do it all the time, and it works phenomenally. Shot? You can see I'm right there at the back of the disc. Oh. Shot? All right. Shot? All right, let's get an AP and just see where we are. Because his spine is so twisty, it's not a normal spine. It makes it very hard to get into the disc. That actually looks pretty damn good right there. Let's go. Come on, Jordan, move it. I don't know if you're paying attention, but we're on a timeline here. Incision. Any questions?
Yes, we have a good amount of questions. Next one coming from Faisal, once more on Facebook, asking, Doctor, what is an A-lift and why is it promoted a lot as a good surgery? Thank you.
I heard what is an A-lift and why is it what?
Why is it promoted a lot as a good surgery?
Oh, A-lift is a horrible surgery. It was the original way of fusing the lumbar spine. I never do it because it's such a bad surgery. It's promoted a lot because orthopedic surgeons when they do spine surgery, that's how they're taught to do fusions, is ALIF. Okay? That's mostly taught to orthopedic surgeons nowadays because they're afraid to go in the back of the spine. The orthopedic surgeons are afraid, are afraid of damaging the nerves in the back of the spine. Okay? It's true. That's why they go through the front. The problem is when you go through the front, which is what an ALIF is, you can damage the nerves in the front of the spine, which then you lose sexual function as a male, and as a female you can also lose sexual function or control of your bowel and bladder. So to that orthopedic surgeon, it's better to lose sexual function for a patient than to lose other functions. So take it out. That's why they do the ALIF. Let's get another AP. I just want to see where we are. Shot real quick. And yeah, see, it's spreading the disc open, so that's good. Nope. Quick AP. Shot. Quick and lateral. That's good. We're there. Very difficult, but we're getting it. He doesn't like that. Shot. All right, let's put that down. Let's take a quick look. See what I can do here. There's really not much I can do here, but I'm going to see if there's an inflammatory spot. Shot. Scope. So we're right at the back of the disc. We couldn't get in because there's two collapsed and two arthritic and it's like scarred together. ALIF stands for anterior lumbar interbody fusion. That means you go through the belly. All right. Perfect. There's the inflammatory tissue, you guys. Look at that thing. That is exactly what I wanted to see. I am so happy it's there. Easy to fix. And we'll be out of here in about 30 seconds. Because there's not much here, right? There's not much herniation. It's just the inflammatory tissue. That's it. The rest of the disc is just scarred and the rest of the disc is not causing symptoms. So that's why we don't do anything with it. Shit. Come on. Get this thing out of the way. Grab her. Come on. It's a little disc herniation and it doesn't want to come out. It wants to block my view. Oh. Unreal. This just has to sit there and block my view. All right, any other questions? Yes. We're going to be done in about 10 seconds and we're going to go to his facets.
Next question coming from the Classic Car Nut on YouTube.
Welcome to our live stream.
Saying, hi doc, have you ever treated anyone with cauda equina syndrome? How rare is it? Thank you.
Yeah, cauda equina syndrome is when you have stenosis or narrowing with pinching of the nerve roots and more than one nerve root's being pinched, and it's being pinched inside the spinal canal where the nerves are typically, but you can also have pinching in the foramen where we're treating it right now. This patient has cauda equina syndrome. He has nerve damage from pinched nerves. It's when you have multiple nerves on both sides, typically left and right, and they're pinched by stenosis. That's exactly what he has. He also has back pain. So we're fixing the pinched nerves and the back pain both. All right, we are done with this. We're going to have to take the rest of the questions in the next surgery. We're going to end the stream. We're going to come back with our facet treatment, lumbar facets. Thank you very much. Thanks for joining.